All right, welcome everybody. I think still some people are coming in, but due to time issues, I think we have to start on this session, which is going to turn around lifetime management of our patients with severe aortic valve stenosis. I have really the pleasure of having real experts and an esteemed panel here. I have Helge Mulman here as spokesperson. We have Nicole Karam, Darren Milet, Andreas Rook, Kim Wong Kim, Arif Kokar and Rui Teles in the panel. So let's start right away because we have quite many presentations to make. So what are the objectives of this session? Well, to learn which aspects are important in this lifetime management of patients with severe aortic stenosis. Also importantly, to understand how these different TAVI platforms compare when considering lifetime management, to experience the added value of simulations when planning for coronary access after TAVI and redo-TAVI. And I think also Arif has there really very nice additions with some of his bench testing. So Nicole, I'm going to invite you as the first speaker, and it's super brave you came up, I would say, came forward, because I heard that you had a broken shoulder a couple of days ago, so I can imagine how it feels, but still it's super nice that you came up, and please have your talk.
Thank you. It's never a good time, but yeah.
No.
So, hello everyone. So I'm going to start the discussion basically for the session and discuss with you the important aspect when we want to select, to treat patients with TAVI. Here are my conflicts of interest. So as you all know, today the indications of TAVI have really evolved. Initially, we treated patients who were not pre-mortem, but let's say very high risk, prohibitive risk, elderly. And today we are dealing with patients who are younger and younger, and getting them through the procedure is not enough anymore. We want more for them. Immediate result is still important, of course, and it's also building the future, but it's not enough. And it's becoming more and more important to choose well the initial valve, but also to know how to implant it. Just to give you an idea of what we are treating or whom you are treating today, basically, if we look at this chart from the United States and you see how the situation have evolved in the last years, we see that the numbers are really increasing in patients below 65 years old. And today, most of the patients that are being treated, the largest portion is actually 65 to 80 years. And if we combine 65 to 80 years and less than 65, then they are beyond 50%. So obviously those are patients who are gonna live long. And initially when we wanted to treat the patients for TAVI, we were really focused on acute outcomes, which are still important. I mean, having a procedural success is important. Minimizing paravalvular leak is important, whether on the acute phase and on the long term. Low gradient has been worked on for years, and if we look today at the scenery and the results, we look, for example, here with ACURATE, we see that we are on single-digit mean gradients today, and that these results do persist over time. So we kind of accomplished the initial mission. Another big issue with TAVI was pacemaker implantation, and this is also building for the future. And here it's very important to know how the valve functions. And here, an example of ACURATE Neo again, but this is a Neo 2. And we know that there is a depth that we need to achieve to have good results on the hemodynamics, but also what we know from ACURATE Neo is that the maximum radial force is not really on the depths of the valve. It's rather higher, which makes the pressure on the conduction system lower. And here again, we see that today we are with single digits number when we come to close to single digit number when we are talking about the risk of pacemaker. But this is not enough anymore. And we discovered the other side of the iceberg. And now we know that what we need to really build for and work on is actually lifetime management and what happens next. So we want to think today about those patients who are going to have coronary access in the years after. We need the valve to be durable. We need the valve to stay as much as possible. But we know that whatever we do, we are going to have degenerated valve, and we are going to need sooner or later to treat that. And this is also important. And in the middle of that comes commissural alignment. That seems to be quite a link between having a good hemodynamics and good results initially, but also not good lifetime management. So if we look at the a coronary access, we have to know which valves we are dealing with and how they are built and how deep we want to implant them and what is the future relationship with the coronaries. Second thing, regardless of the type of valve, is also the commissural alignment. Here you can see an example of aligned versus misaligned valve. And obviously we see that if we are well aligned, then we can make sure that afterwards we are going to be in front of the ostium if we try to go back to the coronaries. And that's why we shifted for cusp overlap view and more for this alignment. The valves are not providing some fluoroscopy visible images so that we can use them to be able to position the valve with the commissural alignment. So it's becoming a requirement. It's not just excess of care, not only for coronary access, but also it's also useful for coronary flow filling, to avoid central leak, to avoid paravalvular leak, to be able to discuss redo-TAVI. So basically, commissural alignment is today a must. And the other two factors which are treating the degenerated valve and the durability are going to be discussed by my colleagues, but those are the other two tasks that we really need to think about when we choose the valve. So today for a procedure, we have to still think about procedural success, but also about the coronaries in the future, about the durability, but also about we have to keep in mind that most likely this is only the first procedure of the patient. There will be another one, and we should be able to treat it and to prepare from it right from the first procedure. And with larger choices come bigger responsibilities. So today we have to offer what is best for our patients because we have the choice. Thank you for your attention.
Thank you, Nicole. Maybe a question already to Andreas. This is now pointing out that beyond optimizing our procedural outcomes from PVL, pacemaker, etc., we have to have attention to these other factors as well, like commissural alignment, maybe durability, coronary access. How much is this applicable to your practice, for example? If you do TAVI nowadays, do you take all these aspects into consideration?
I would say so. First, on the commissural alignment, which has been worked on both in Copenhagen and Stockholm, we think nowadays it's really easy to accomplish this, at least with the ACURATE valve. It's more or less a no-brainer and takes just a minute of the procedure time. So that's something we always do. I would, though, say that, of course, that minute invested, it's not much, and most of the patients actually don't need to come back for a second valve and don't need to come back for a coronary access. But still, if they do, it's of course good that we've done it in the first place.
Mm-hmm. Yeah, exactly. And Darren, maybe in your practice, because we're going to talk further about TAVI device-specific issues, but I want to stretch it to the patient. Which kind of patients do you encounter where you think this is particularly important, these lifetime management aspects? Which particular patients do you, in your practice, think this is really where you have to consider these aspects?
So I think the mean age of TAVI in our population is still 78, 79. It's coming down, but very slowly. So to be honest, the vast majority of patients that we treat are still very elderly, and lifetime management is not necessarily an issue for them. But as Nicole has showed us very clearly, organizing things such as avoiding pacemaker, ensuring no PVL, commissural alignment, all of those things are not necessarily just for younger patients. They're also for patients who are multimorbid. If you've got a patient with bad coronary disease who happens to have aortic stenosis, part of their excellent management is to make sure you have access to those coronaries in the future. So I think the same principles can be applied to elderly patients and younger patients who are going to require a second procedure. I think the one difference is that when dealing with those younger patients who are going to need a second procedure, we now look at the time of the index implant, what valve will we put in now that is going to allow us to do a second procedure in due course? We don't necessarily do that in the 80-year-olds, if I'm being honest.
No, but I think that was also my point. So many of these aspects that Nicole brought forward of what is important in the lifetime management, I think these are indeed also factors that maybe play in your elderly patient a role, like the commissural alignment, the coronary access. We think this is only relevant for our younger patients, but that's maybe not true. And indeed, as Andreas says, if it's an easy thing to obtain commissural alignment, why not do it? Indeed, then that's true. So I think we move on because we have quite a lot of things to handle still. Darren, you're going to go more specific about the designs of what is the impact of these different TAVI designs in the light of this lifetime management, yes?
Thanks, Ole. So I'm going to keep this reasonably simple and reasonably highbrow because, of course, each of the various systems that we have available to us have very specific design features that can be either advantageous or disadvantageous in a particular patient. Index procedure, as Nicole has outlined, is really important. I think the other important thing is it needs to be easy. Right? I think we forget about that to a certain degree, but we don't want to spend a lot of time performing complex maneuvers in these patients. We want to get in and get out because we're doing many more procedures each day. And so I think the one thing I would add to what Nicole mentioned is easy access and simple deployment. If we think about the long-term aspects of valve choice, really it comes down to three issues. Valve durability. Is this valve going to give me 8, 10, 12, 14 years? Second, compatibility for redo-TAVI. Can I revalve this patient in due course? And third, have I got good coronary access now? And will I have coronary access if I do a valve-in-valve procedure in the future? Really, to my mind, they're the features that are important for lifetime management. If we think about coronary access, cell size is important. So if you think about the cell size, for example, with a Medtronic Evolut and the cell size with an ACURATE, these are my own drawings on the side of the envelope. They're quite different. So not all self-expanding, tall frame, superannular valves are the same. The second thing that's important is that it's not just about cell size. It's about commissural alignment, and it's also about commissural size. Look at these two different sizes. You have a big commissure post and you have a narrow commissure post. So if you get a narrow commissure post that happens to be in front of your left main, you may be able to get around it. If you have a much wider commissure post, that may be more challenging. So again, each of these different valves have advantages and disadvantages. It's also important to consider leaflet height. We know that the depth of implant for the vast majority of our valves has changed over the last number of years. With our desire to avoid pacemaker, we've gone higher and higher. That comes at a cost. Now, in an 80-year-old, that probably doesn't matter. In a 60-year-old, going higher means you're going to have more leaflet across the coronaries and maybe have more trouble in the longer term. The one difference is that in accurate implantation, you don't want to go higher. You want to implant this valve at 5 to 7 because that's where the radial force is. Higher implants give you more leak, higher risk of pop-up, and more complications with an accurate. And so again, when trying to figure out what's the right valve for your patient, you need to look at their anatomy up front, and you can choose any of these for a given patient. If we think about THV classes, we have balloon expandable, we've got your typical long frame self-expanding cages, and we've got maybe those novel self-expanding valves. And if we think about those broad categories, what are the advantages or disadvantages as it pertains to lifetime management? Well, balloon expandable, index outcome, excellent. We know that with SAPIEN 3. Commissural alignment, not possible with current generation devices. That's a limitation. Coronary access, usually the device is underneath the coronaries, but in 30% of cases, that's not the case. That may be an issue in terms of revalving in due course. But generally speaking, with low frame devices that can be underneath the coronaries, revalving is a good idea. Durability, we've seen some issues with earlier incarnations of the SAPIEN 3, the SAPIEN XT, but we've just had the durability potentially increased with the RESILIA tissue. We'll have to wait and see. If we look at the typical self-expanding devices, again, we know that we get great index outcomes. 97% of evolutes can now be broadly commissurally aligned. Coronary access remains a problem with this system. However, we saw at the start of this week in the US the first Evolut FX Plus devices used, and they have large windows in the stent frame to assist for coronary access. Revalving, we still have very high leaflets with this device. It's what gives good hemodynamics with this device, but revalving can be an issue, and durability, I think the Notion 1 data tell us that this is a very durable device. Novel self-expanding devices such as the ACURATE Neo, the index outcome, in my experience, is excellent. It is the only device that we can individually commissurally align for each individual patient. Coronary access is not a problem, as I showed you the size of the cells and the commissural post. Revalving, I think it's important to show the revalving issue here, that while these posts can be, or these leaflets are high, and maybe Arif can show us this later on, what you'll notice is that the stent posts are actually inside that upper crown. So you do have some space over here on the outside of the frame. That should allow us to revalve patients that we can't do with those typical self-expanding devices. Durability, we have 5-year data. Helga, your data from your intervention was impressive. But again, we don't have 7, 8, 9, 10-year data. So to summarize, all transcatheter heart valve have advantages and disadvantages. But the great thing is that we have a variety of devices that we can now select for each individual patient. Longer-term outcomes should be considered in all patients, especially those that are younger, and simulation for revalving should be part of what we do day to day in those younger patients for sure.
Darren, thank you very much for this very nice overview of the different devices, of the different designs we have. Actually, I would like to start with a question to you, because you made these 3 points. We have to talk about durability, we have to talk about redo, and we have to talk about coronary access. Isn't there a 4th point with pacemaker, which may be for lifetime management a very important factor?
Maybe. Maybe. So, of course, we've all been striving to avoid pacemakers because we believe that left bundle branch block, right bundle branch block, pacemakers are not a good thing for our patients, right? And I think that there's reasonable evidence out there to suggest that that's the case. But if you think about, for example, ACURATE Neo, 6% pacemaker rate, and we know that if you look at people who get a pacemaker, 50% of them to 60% of them are not using it in a year's time. So in fact, what you're looking at really are 3% of your patients who are going to be paced on a long-term basis. That's not good for those 3%. But if we start putting these valves higher and higher, you're probably going to take out 25 to 30% of patients who have a revalving option. So you have to balance that in your patient. So for me, an 85-year-old, I don't want them to have a pacemaker. And a 65-year-old, I want to be able to revalve them. You can't have it all. You have to make a decision.
Well, maybe you can have it all because, as you said, I mean, this valve, you typically do you compromise sometimes on the depth you implant in ACURATE Neo 2?
No.
No, so in a way, I would say you don't have to compromise here. You still keep on doing your traditional implant depth of 5 to 7, which is the nominal implant depth. And despite that, your pacemaker rate is single digit, yes, like as low as 6%. So maybe you have so much experience with this particular valve, because we're talking about the design of these specific valves, what makes you say this valve is, what aspects of the design makes you say this is a great valve for lifetime management of your patients?
Very good question. I think there is no valve, first of all, that can be used or is 100% suitable for all anatomies. So far, I think there's no super valve. And so I think it's important to look at each individual anatomies. And regarding the ACURATE Neo, I think it's a combination of a lot of favorable features that you have. There's a combination which you don't rarely see in other platforms, and this, I mean, you have mentioned it already. It's the ability to have very easy commissural alignment. It's straightforward. This allows for better coronary access. This platform actually is the valve with the lowest risk of coronary obstruction. Yeah, this has to be emphasized. Then you have the same hemodynamics as the Evolute, so supraannular characteristics. At the same time, you have much better coronary access. So, I mean, there are a lot of beneficial aspects. Of course, there are also some limitations, and I think you have to weigh whether a valve is suitable or not, and yeah, this has to be taken into account.
Indeed, and I think from my own experience to share, I think how you look to this valve, if you put the valve on your table in front of you, you can actually really appreciate that it's, people call it a long stent frame. I don't see it particularly like that. You kind of have a stent frame which is pretty low. Actually, even if you implant at a nominal depth to be lower, the top of the upper crown is kind of lower than even for a sapien. And then you have these very large stabilizing arches, which are, you can almost ignore them from a coronary access standpoint of view. So, and Arif will show that quite nice later. Maybe you can make a drawing, Arif, we can draw there and explain us a bit more there already.
Yeah, I don't know if we have the pen just here, but as you can see, talking about this concept, you've got the actual valve and then on fluoroscopy. And yes, on the one hand, you know, we talk about it being a tall frame valve. So we've got, don't know if that's working or if we have a pen, but you can see it's a tall frame valve here. Say that again, sorry. Ah, perfect. There we go. Thank you. So you can see you've got a tall frame valve just over there, but the difference of the split level design, so it's really split into two halves. So your barriers for your coronary access, your catheters, are all located here. And if we're implanting at 5 to 7 millimeters, really that's a very short segment that is a problem. And then above, you've got it much more open and
maybe
much more free.
can you indicate where your annulus preferably is there compared to the crown, the upper and the lower crown there?
Unfortunately, the pen's not working, but
it's not working.
we can just show that there. There we go. There. So you can see almost that really, when we talk about it's a tall frame valve, and as I think, Darren, you said quite nicely, not all tall frame valves are made equally. And here you can see this is really split at this level between, that's the frame, the stent frame segment, and then you've got the open arches higher above.
All right. Thank you, Arif. And I think there's a question, Helge, you wanted to...
actually, there is a question from the audience, which is a really good question. What should the procedural strategy be when aiming for commissural alignment in patients with coronary overlap and or coronary eccentricity, for example, in bicuspid? So in bicuspid, you cannot really align the valve. Von, what would be your...
Very good question, difficult question.
That's why I'm asking.
Yeah. I think it depends on the type of bicuspid valve. Type 0 is a different story. It's relatively rare, 5%. I think most patients have actually 3 commissure with fusion, so it's mostly type 1. There can be eccentricity. And to be very honest, in most cases, I just try to achieve commissural alignment. I don't think you need to be perfectly aligned, but I think there are other experts that have much more knowledge regarding coronary eccentricity. Ole, I know you have been very...
Yeah, we investigated this, but maybe Andreas wants to share his experience or opinion on that too, no?
Well, if you're really interested to get the perfect alignment to the coronaries, you can actually, on the trimensio, place dots where the coronary ostia are, and then you get your fluoroscopic views that you should use to get the coronary alignment as opposed to the commissural alignment, although in most patients it's really close. Yeah. That's what you have studied, I think.
Indeed. So as a summary, I know this topic pretty well. We studied this, and it's actually, it doesn't make any sense to do coronary overlap. I mean, this is total nonsense to me, because if, first of all, it's a small difference, and if you want to correct for it, it means that you do your implant even in a more areocaudal. So it's sometimes in your cusp overlap, you're already pretty areocaudal. So we study this, and if you do the coronary overlap, it typically means you have to add 5 to 10 degrees more areo and caudal. So that's even harder in practicality to do. And on top of that, a left main in the tricuspid valve is almost super strict, very central. It's typically the RCA ostium, which is more to the NCC, RCC commissure, sometimes a bit more eccentric. But the thing is, if you want to compensate for that, then in a way you sacrifice a little bit your commissural post compared to the left main. So you don't gain a lot with it, I would say. So and then you also your commissural alignment aspect, you sacrifice. Then you only focus on your coronary ostium to put just one post just right in the middle between the two coronary ostia, but you don't maybe you sacrifice a bit of your commissural alignment then. So I think this is not an issue. I mean, we should not think about coronary overlap. Let's stick just to the commissural alignment. That's my personal opinion about it. So I think we have an integrated case in this, and that's thanks to Rui Tilles. You recorded a case, and you're going to share this with us, but maybe you first want to present your case, yes?
Okay. So first of all, thanks for this opportunity on behalf of our team in Santa Cruz, Lisbon. So this is a straightforward case, I would say. in most of its parts. I will present it very quickly so that you can discuss how to approach these patients. But the bottom line is that we like to show how to perform a case in a patient that is young and has low risk. And that is the purpose of this presentation. So it's a 75 years old female. She's in New York Heart Association class 2. She's an hypertensive female. And she has COPD that is under medication currently all the time. So she has really a COPD. Her ECG has no white band and blanch box. She's in sinus rhythm. The echo shows that there is a straightforward like aortic stenosis with a mean gradient at 44, good LV function, and no particular issues regarding the renal function, and also a progressive increase in pro-BNP that is consistent with the symptoms. So when we look at the CT that was performed before the procedure, we can see that there is no particular problem regarding the femoral diameters and the iliacs. They are quite large, above 8. There is a slight moderate tortuosity in both the right and the left femoral, but the bifurcation is low in both sizes. Regarding the annulus sizes and the anatomy, what you can see is that this is an annulus between 12.9 and 23 millimeters elliptical annulus. The sinus of Valsalva are quite large, between 28 and 30. The STJ is 28, so there is no striking problem regarding this. The coronary height is between 11 with the left main and 13 for the RACA. And here you can see that we are going to calculate what is the area and the perimeter. That's 45 regarding the area, and the perimeter 69 with the perimeter derived annulus of 21.3. So that in the end will allow us to perform a case with the proper sizing of the valve. It's not a size that raises much doubts regarding what is the final aim of any valve in this regard. So regarding the procedural plan, as usual, we'll have to think about the several steps that we have ahead: anesthesia, femoral access, pacing, pre-deal, post-deal, coronary protection, closure devices. And we're going to use a straightforward plan because it's the usual one in our cath lab. So it's conscious sedation here, right femoral access with the eye sleeve sheet. The secondary access is by the left radial to decrease, of course, the access problems. LV wire pacing with a Safari extra small because the LV is not very large. P-deal with a nucleus lumet 20, so below the 21.3 of the annulus. No coronary protection as you saw. And of course the calc rate that we're going to use is NEO2 23, which is according to the range of the annulus. Closely device the manted 18 French. So having said that, I close this case presentation. I leave you for discussion.
I think we need a discussion on that first, yes. So maybe we can start with one. I mean, first about the indication for this. So this was a 75-year-old patient. Okay, she had some COPD. What do you think about the indications? Clearly she has indication to be treated. Would it go to TAVI surgery at your center? How would this be discussed?
I mean, in Germany, the age cutoff is 75, so I think this wouldn't be any issue. And giving an average life expectancy of, I don't know, 80-some years, I think she's a very good TAVI candidate. Given the COPD, open heart surgery could be an issue. So I don't think there would be much of a discussion. She has a straightforward TAVI anatomy that would preclude relevant procedural complications. So, yeah, from my point of view.
Any other opinions in the panel here or in the audience about the indication first for TAVI? If there would be, let us know. But otherwise, on the CT then, the CT part, maybe Rui, you can discuss yourself. So what is important here in your selection to go to choose for an ACURATE? What were the main factors that led you to this decision?
I think actually there are little factors that can exclude an ACURATE for in most of the patients regarding the anatomy, unless the femorals are rather small, below typically 5.5, or unless the annulus size goes above the range of 27. That means that in all the other cases, I think we can move forward with the ACURATE. I would say that no valve is excellent for LVOT calcification, for instance. No valve is extremely good for low coronary takeoff and small anatomies. But in this case, that is not a question. So I think there is no specific exclusion factor here. And basically, I think the good point that was made already is that when we are looking at younger patients, we are looking at patients that will need to have to keep on the coronary access open, and also to avoid pacing. No risk of pacing here. Here I think ACURATE is an excellent choice, because I think both problems can be avoided, I would say.
But Nicole, how does your choice go? One thing that catched my eye, two things, is first of all, it's still a rather small annulus, yes. And then it was a very severe left ventricular hypertrophy as well. So maybe does this have consequences on the choice of your valve you make at your center?
Yeah, of course. The size of the annulus is paramount when we want to decide for the valve. It's very important, as we said so far, that we get with single-digit gradients. So we'll definitely go for a valve with a good hemodynamic profile. Regarding the hypertrophy, yeah, it is there, but I'm not really scared of it. So my choice would have been rather driven by the size of the valve, the annulus.
Yeah, indeed. Any other opinions about whether this left ventricular hypertrophy can have some consequence for your procedural approach or not?
I would actually like to have another comment on that.
Okay.
Sometimes when we discuss with the surgeons, we also take the annulus size into account, meaning that the surgeons will barely bring a 21 millimeter bioprosthesis into this annulus, which might be problematic for the gradient. So that's also an argument for doing TAVI rather than putting a surgical bioprosthesis in this patient.
Mm-hmm. Except if they do annular enlargement. I don't know if they do it a lot in your center.
Yeah, but that adds some complexity, but it's true. It can be done.
Mm.
Maybe I can add one question also to the panel. If you see this severe degree of hypertrophy, what you're talking about is probably a suicide left ventricle. How frequently do you see that?
Super rare, yeah. But it happens, yes. I mean, it happens.
But actually, I would say that most of the times I'm more concerned with transthoracic echo rather than the CT, because in the echo, I think I value more a septum of 17 in the echo rather than in the CT. It's a different animal. So I think echo is still the way to assess the hypertrophy rather than a CT.
I agree.
And maybe one more factor that you might take into account when considering valve choice is this lady, while she has a small annulus, has big anatomy, right? Her STJ is 28, her sinuses are 32. And so maybe in this slightly younger patient, you might say, well, let's take a small frame valve because we're not going to cover the coronaries. Coronary heights are 13. So with any valve, you're going to cover the coronaries. But because she's got this capacious anatomy, I don't think that revalving this is going to be a problem with any prosthesis. Right, but I think it's always important to think about that. You have a question over there. Is there a microphone that we can? Yeah, thank you.
So we know that the annulus is small, so a self-expanding valve gives better hemodynamics. Now, when compared to Navitor, vis-a-vis an ACURATE Neo, what are the factors why would you like to take ACURATE Neo instead of a Navitor in this case?
Do you want me to?
Yeah, well, I have experience with both devices. It's not, well, look, I think this anatomy could be treated, as Rui said, with almost basically any valve, but I could have a preference for ACURATE in the sense that if you go for example, a Navitor platform, what I do more like for this platform is that at least you implant a valve, you try to implant relatively high, and then the stent frame goes quite high up. If the STJ, as Darren is pointing out, is rather spacious, the valve doesn't get any stability there. Yeah, so you don't get extra stability of your aortic root. So in that sense, you could have a preference maybe for the ACURATE platform. Has almost never. It never really touches with his stabilizing arches to the aorta, because it's even a little bit more to the inner side. So it's fully depending only on the anchoring with the lower part, yes, below the upper crown. So in that sense, you could have maybe a smaller preference for that. Also, the lower pacemaker rate could be an argument, but I mean, look, many patients are treatable with multiple devices. Yes.
Another thing is that the main deterrent of the pacemaker rate is the depth of implantation. Initially, when the TAVI valves were started being used, then the valves used to be implanted at a depth of 5 to 6 mm, the self-expanding valves. But since the pacemaker rates were high, so people started going to level 1, level 0, and so on and so forth. Now, this valve is implanted at a depth of 7 mm. Then how come the pacemaker rates are in single digits?
Because it's implanted differently, so it's not opening up from the bottom and going to the top. It's from a top-down deployment, so it opens up. Maybe we have some slides about it. I don't know, some backup slides. But actually, during the process, we will see it during the recorded case. The valve opens up at the top first. Then there's an upper crown which you push on top of the leaflets, and then you expand it. So you never really interact with that LVOT. Yes, because you don't have an opening from the bottom and you scrape on the membranous septum. You don't have this with this valve. And it's repetitive in all registries, all studies. This valve is really, that's something what I'm like about it as well, even more than the hemodynamics, I would say, is this extremely low pacemaker rate, because it's so important for our hospitalizations that these patients can go quickly out of the hospital again.
Can I say one more thing? The reason that the pacemaker rate is so low is that when you look at Evolute and you look at Navitor, it's the very bottom of the frame. That's where the radial force is. That's what's pushing out. It's not the case with this valve. The radial force is 5 to 7 up. That's why if you implant this valve high, you don't get any benefit. You lose because you get more PVL, you have less radial force, and it pops up. So you implant this thing at 5 to 7, but know that what's underneath in the ventricle, in the LVOT, is much softer than what you get if you implant an Evolute or a Navitor, for example, at 5 to 7.
And I would add, I think the average implantation depth is not 5 to 7. We get 4 to 5 on average.
That's true.
That was actually something I was willing to add.
Sorry.
Because I think, if I may offer a comment regarding the implantation. My name is Gindas. I practice with oil in Copenhagen. So I think this is not only the depth below the annulus what you look at when implanting this valve, but you want the crown to be above the leaflets. I think that's equally crucially important, and depending on the height and tallness of the leaflets, this valve could be also at 0, or just 2 millimeters below the annulus, because length of leaflets define how deep it goes. That's my understanding about it. I would love the panel to comment.
But that's true. I mean, I can only confirm that, because this is another mechanism. So the valve, indeed, that upper crown, as you will see during the case, you have the best results when you get this implanted just on top of the calcified leaflets. And we have even investigated it, one thing together, where we indeed measured the average implant depth, and indeed it's true. We compared implantation in tricuspid versus cusp overlap. Didn't make any big difference for this valve, because the leaflets determine how high the valve actually finally ends up to be sitting, and that's why he came up with the numbers of 4 to 5, because that's what we found in our study, that indeed official instruction for use says, it implanted at 5 to 7, but it's the leaflets who determine where it sits, and it's actually 4 to 5. Yes?
But I think it's important to mention that we start at 5 to 7, and it will level up to whatever.
Exactly.
So I think it would not be a good idea to have a look at the leaflets and say, in this case we're starting higher. So we should always start at 5 to 7 millimeters, and then it will self-level out. We have to keep a little bit the time, but there is one question with a very short answer for you. Cerebral protection, yes or no? And when?
Easy question.
Short question, short answer.
The cardiology evidence-based response is that the supporting data is a little bit weak, but there is reportedly a UK study coming out sometime, which will be the largest ever in the field. So I don't know, is there any news from the UK when that will come out?
Not yet.
So it's at 3/4 of its recruitment, as I understand, and they've decided to increase the sample size because I believe that the unadjudicated rates are a little bit low, so they need a bigger sample size. So this is 7,000 patients, and now it's going to go to 9,000 patients. What that tells you is that the margin of benefit is,
Quite small.
to be determined. So. A great study, and a study that's absolutely needed, right? It's going to tell us definitively, does the Sentinel device reduce stroke or not? But it's going to be another 18 months to 2 years, I would presume. I don't know, is Raj here?
No, and we go forward.
Short answer, no.
Let's move to the case because we are going a little bit, we're quite on time, but 4 minutes late, so let's move on with the case.
So this is a recorded live case, so I won't just say anything while it starts playing. So
We don't have it on. Can we have it?
Yeah, okay.
Ooh, big team.
So this is our team. So
75 years old female. I will discuss the clinical issues in a moment. So I'm here with me, who tells at Santa Cruz. I have João Brito and Afonso Oliveira, the anesthesiologist Paulo Ratinho, the nurses Natasha and Paula Castelão, and Raquel from X-rays. And finally, Celia and Ana Monteiro from the technicians that will support us in this case. You are welcome to the session, and it's a pleasure to be participating in PCR with you this year. We'll start right away with a femoral approach on the right and the left radial on the secondary axis. So this is the first axis, a left radial with a 6 French catheter. So we have here, you can see that we have to puncture from the outside, since we have that small vessel over there. That is like perhaps like a 1 millimeter vessel, but that might cause some issues. So let's try to avoid it. So I'm going to insert more wire. So let's exchange that for the manta. Looks like 6. So now we have exchange. We're going to exchange the wire for the phi, so that we have a higher support when we advance the eye sleeve. So now we're going to advance the eye sleeve across that towards anatomy, and that might induce some pain. I expect that. Let's see how it behaves. So you can see that I'm going smoothly and while rotating as always, but the patient is complaining a little bit, but in the end, I think we have overcome most of the anatomy at this stage. So at this stage, we gave heparin, and we're going to move with the next steps, which is to cross the valve to assess the gradients and to prepare for the valvuloplasty. So while the valve is being prepared, we're going to perform these steps. So this is the first. We're going to exchange the Safari with a soft wire so that we can progress across the arc without touching or causing any sort of disruption. So you can see the calcium over there. This is not a much calcified valve. The calcium score is 1,200, so it's not a major classification.
First time.
Can you see 39. The polygraph? So we have a 39 medium average gradient. I always like to manipulate the pigtail to understand if it is free around the LV, and then to let it position at the tip, at the apex, so that we are sure that we can later on have a good wire position that does not jeopardize the position of the ACURATE Neo. So let's see how the wire behaves. It looks so far very, very well. Okay.
Nice.
So at this stage, we can say that so far it's a straightforward procedure. The only difficulty that we faced that was not difficult to overcome, although the patient had some pain, was the right iliac and femoral system virtuosity. But the calipers are excellent, so that does not concern me a lot, I would say. So now we're going to advance with the with the balloon. We are in the cuspid overlap projection. We're going to move to the 3 cusps. So João is holding the wire while I'm going in, just to avoid much LV. Okay. So at this stage, I think we are in a good position. We have already tested the pacing. It works fine, but we'll do like 180 pacing here. So we're going to remove a little bit the pigtail. And while performing the valvuloplasty, I'm going to push slightly. So, João, pacing on, balloon on. This is a 20 balloon. It looks like, okay, pacing off. Let's see how she behaves regarding the left bundle branch block. Okay. So far, so good. Nothing to matter. So here our main concern is to have perfect result regarding the long-term performance of the valve and the coronary access.
Okay, I think we have there a small pause in the video because there are a couple of things we want to emphasize which are important so far. The first thing is the wire positioning. Maybe Helge, you can comment on it. How important is it to have a proper wire in the LV, how it should be positioned, what to avoid on the positioning?
So the wire really adds stability during the procedure. Therefore, it's important to have a pre-shaped wire. Actually, most of us probably prefer the Safari wire. I would prefer the XS, as you did in the case as well. And this wire should be with a loop facing upwards, really deep to the apex, because this gives the stability. This helps that you come on the outer curvature of the aorta, which definitely makes the procedure much safer.
Yeah, so that's one aspect. Then about the balloon pre-dilatation, Nicole, Darren, what's your policy here? Do you always pre-dilate? What kind of balloon size you take? Is it important, not important?
Very important, and there is a lot of discussion. I mean, I don't know where it comes from, sizing the balloon according to the minimum diameter. And I think this is okay for other platforms with larger opening force, but for the ACURATE, definitely this is not the official recommendation, and I can only repeat it. At least in our center, we do a relative aggressive pre-dilatation, annulus diameter -1 or 2 millimeter, depending on the degree of calcification.
Nicole?
Yeah, so just first to add on the position of the wire, one other important aspect is that today we are almost everyone is using the pacing over the wire, and it's very important to keep the contact on the pacing because at some point when you were using balloon self-expanding valve, we used to move a lot the wire, and this is something to keep in mind when we are using when we are pacing over it. For the balloon size, usually it's so here it was a 23 valve with a 20 millimeter balloon. So this is exactly what we do usually when we want to pre-dil. Just
so you would have matched also more with the 20. I can feel that one would have gone for a slightly bigger balloon. Yes.
Yeah, 20.5 actually.
When you say slightly, it is slightly.
What was the perimeter derived mean? No, maybe 22.
It was 21.3.
Yeah, it really depends.
You would have gone for a 22, no?
Sometimes. It really depends on the degree of calcification, whether I expect requirement of post-dilatation. So you could eventually use the same balloon, but something in between.
Darren, same opinion?
I think there's this idea that pre-dilatation is a bad thing. And I think it came from the time when we were doing TAVI, where we were doing TOE sizing and we didn't have CTs to get the right size balloon and so forth. We don't see more stroke with ACURATE Neo, where we pre-dilate 100% of the time than we see with other systems. Why is that? Well, because the balloon is not responsible. My feeling is, so the perimeter of this was 69, divide that by 3.14, it's like 23. So for me, this is a 22 pre-dil, but it's actually a 22 true pre-dil, because the NewMed is a relatively dog-shaped balloon. I don't like post-dil, but I don't mind pre-dil. So I will pre-dil a little bit more aggressively and hope to reduce my post-dil rate. Because with this valve, very often you put it in after a good pre-dil and the case is finished. There's no leak. So for me, that would be a 22 true in this case, but cognizant that everybody has slightly different practice. But I think what you're hearing from us is do a proper pre-dilatation with this system.
Just to make it clear, wasn't it a 21.3 annulus?
Yeah,
So,
it was.
yeah.
So
21.3.
I would just had a
I
small
thought it was
comment
big.
that is
Yeah.
so this is not a very calcified anatomy, so we are not in a. So I think if the calcium score was quite high, we
Yeah.
would go for an higher
Aggressive.
If
aggressive.
it's 21.3, it should have been enough. But indeed, I mean, the pre-dilatation is half of the success. I mean, that's the point. I mean, the valve implant itself is pretty straightforward and easy, but if you fail in doing a good pre-dil, you can bring yourself really in trouble. Yes. So I think the pre-dil is absolutely key. And also, this valve can be used definitely in all spectrum, from really lightly calcified to really severely calcified too. That's what me and my colleague also do. But then in these particular cases, if you use this valve in really severely calcified cases, we really make sure we have a very, very good pre-dil. And if you do this, you have excellent outcomes, to be honest. Yeah. So then what we do is sometimes we do we repeat the inflation of the pre-dilatation, and that goes actually really well for us too. Yeah.
And in an areocaudal.
Sorry?
Right, an areocaudal. So if you've got a very heavily calcified or bicuspid valve, don't do it in AP, do it in areocaudal, because that's the short axis of the aorta, and you can really tell, have you done a good pre-dil? And sometimes you haven't, so you have to repeat it.
Yeah. You had a question?
No, just a comment, because somebody was asking whether the pre-dilatation should be done in all TAVR cases, or whether this is especially for the ACURATE device. And I think we have to clarify that a little bit. It's especially important for the ACURATE device, but probably does not harm for the other devices as well.
No, let me just put one prerogative comment. You know, in coronary, we have a paradigm shift, right? We had a phase where we did direct stenting and we didn't care about calcification, no preparation. But now we really care about pre and post dilatation. And I don't know whether for TAVI, this could be the same.
I agree. I mean, if you look, balloon expandable technology, you use a balloon there anyway, yes, to put the valve. But in self-expanding technology, I've also never gone into the hype, I would call it, to use less and less pre-dilatation, because what happened, if we talk then for Evolut, there has been a real hype to say, like, you were the cooler guy if you said I pre-dil less. And what happened is, they were suddenly facing infolded standing of their stent, then also slipping of the valve suddenly down or up. And that's all because you have an underexpanded valve. If you really prepare your landing zone there properly, you optimize your outcomes. And very often you avoid post-dilating. So I think really I follow your logic there. If you use self-expanding technology, TAVI technology, that's for me valid for all self-expanding technology. I prefer pre-dilating because it makes me doing a better, more stable final release of my valve.
Yeah. We did that. We went away from pre-dilatation completely, and then we ended up going back to it because we had lots of bad outcomes. So we and again, the last thing is, what about the post-dilatation, right? You've got no gradient, you've got no PVL, but you've got a frame that's all compressed and it looks terrible. I'm not going to leave that. I'm going to post-dilate that valve. Yes, is there a risk that I could damage the leaflets and so on and so forth? We know with the ACURATE Neo, if it's a 27 valve, you can take 26, you just -1. So if it's a compressed frame, I'm going to open that as well, because I think that's going to have an impact in durability. So I'm liberal with pre and post.
Yeah, so
I'm
this is
the
again what we
timekeeper
are...
again. Sorry,
Sorry.
we really have to go on. Otherwise, we won't make the case to the end.
So I have inserted the system and the coronary access.
Okay, let's see.
So I have inserted the system. Okay. Now I'm going to remove this, and I'm going to use.
So since you're going to repeat the valvulopathy here, I'm just adding that for me, it's a safety issue. Very calcified anatomies with ACURATE to perform pre-dil. Otherwise, you can get stuck with when you release knob 2. So this is critical, I think, also. So.
Okay, as you can see, I have felt no resistance so far. It goes quite smoothly. Actually, this is not a large valve, so I feel that I'm struggling a little bit against the anatomy. Be careful with the wire, okay? Okay. But no issues so far. So we could advance the system without any sort of difficulties. Now we're going to the frequency overlap, and we have it at between 6 and 5. orientation to ensure that there is the visual alignment. So you can see here that we're going to progress, and here let's see how it behaves. So we're going to stop a little bit before we engage into the annulus. Okay, and so I have to rotate counterclockwise slightly to get it aligned. And actually, it's also important because, let me just turn it, okay?
So now you're rotating.
No, it's okay. Okay, I think it's okay, but I'm going to take some time to reposition the pigtail. En daarmee pas ons goed, please.
Was?
Ons goed zien.
Okay.
So it looks like it's a good position. Let's go into the best bit of a lap. Double check how we are. If this is actually, it looks good. We don't need to inject any contrast at this stage. And we can actually start already deploying. So we have a good commissural alignment. Let's go back to the three-case overlap. Since this is not a very calcified valve, we have to be a little bit careful regarding the, but I think this is a fine position to start. Let's do just a small angio here, just to confirm it, and then we'll start with knob 1, okay? Okay. I'm checking the wire position at the apex, it's fine. Okay. So the system is quite external in at the complexity of the aorta, and the position is fine, so I think we can start the deployment. We're going to centralize this. Okay, let's go. I think we are okay. If you look at the calcium, which is difficult, we are capturing it with the arms and go on. So let's do another angio here, and if we are happy, we're going to do some pacing, and then we're going to release the valve. Okay, we have already released the pin, okay? So we have reached the end of knob 1. We're going to confirm the position, and if we're happy with the position, I'm going to push slightly the valve because it's slightly high. Okay, so I think this is as good as we can get with this anatomy. I'm going to improve the wire here, and I'm going to push slightly again, okay? So I think this is a fine position. Let's double check it with the angio, and then if we are happy, we're going to release the valve, okay? Angio, go ahead, Joe. Okay.
Okay, it's done.
The pacing off. So the point was quite stable and as predicted. So remove this, please. We don't need the pacing now. Now we have to be careful, as always, to centralize the nose cone. So the hardest part is already gone, so that's what we can see. Ok, podes filmar então. Agora aqui faz mais, põe mais. Okay, well. So we're going to recover this, and we're going to perform an invasive assessment just to compare with the initial. This rhythm did not change. Before we deployed the valve, we already had this left main bundle branch block that is still there, and we don't find a different. So we have 24 of AR index. Let's do the assessment here. Temos quanto? 22, okay. 1, 2, 3, that's the angio. Okay, I'm happy with the result. The deployment of the ACURATE was not cumbersome. It was according to the plan that we had. So we did a pre-dilatation with the 20 balloon. We deployed the 21 valve. The result was perfect. We had no regurg at all, and no conduction disturbances de novo after the valve implant. And as you can see, The coronary arteries are patent, and we don't have any ECG that. We did close the access side at the right femoral with a manta. I believe the anchor is in the proper place, but perhaps we caught the side branch, and that caused some bleeding, but I think we are controlling it now without any problems. So I close the case, and I appreciate your time, and I thank all the team here for the participation in this case. I hope it was clear for you what is a straightforward case with the ACURATE, and also the advantages of having a good access to the coronaries. See you.
So thank you very much. This was really an impressive case, and I think everybody could appreciate how easy it is if you have a couple of steps which are important. And one of the questions out of the audience was again about the commissural alignment. Andreas, which is the best way to get a quick and near complete commissural alignment?
Yes, so obviously there are three perfect positions since it's a 120-degree valve or 120 degrees between each commissure in the valve and also in the patient. So regardless of how you actually have the flush port, it's just a matter of rotation. But of course you want to manipulate as little as possible, and we actually looked into this in 400 something patients and compared the three different flush port positions, and so far the 9 o'clock comes out as the winner, although by a slim margin I would say. So it's not really important. The company recommendation is 6 o'clock. Probably 9 o'clock is a little bit quicker than your average, a little bit closer to your target already from the beginning.
But I think it's important we emphasize that this is the only valve where you can rotate and provoke some rotation on the valve when it's already across your native valve. This you cannot do with, we tried to do it with other platforms, but it doesn't translate. If you have, then you have to rotate it when it's in descending aorta. So here, the catheter is built up. It's such that you can, if you are already across the arch, you can still rotate, and you can really do this very well controlled. And as Andreas said before, it takes less than a minute. But I think due to the sake of time, we really have to move on. And I think, Arif, it's up to you to say your opinion about the key considerations and simulations of treatment options in the light of lifetime management. I think you've done bench test testing on the patient that Rui treated. Is that correct?
Yeah, exactly. So good afternoon, thank you. So essentially I'm going to show you what cannot be shown in that specific patient in vivo. The topic, of course, is lifetime coronary access, and we talk about different catheters and different techniques, but again, to emphasize, starting with an optimal index valve implantation, a good planning of your redo-TAV strategy, and then using specific techniques if required. So what we did is we took exactly that patient that you've seen, took the pre-TAVI CT scan, and created a digital model from which we created the absolute one-to-one size anatomical model, connected in the simulator and take it into the cath lab. Now in that patient, because the whole session's on lifetime management, we explored 4 different lifetime management strategies. Number 1, putting the sapien in the low position, so outflow to upper crowns, sapien in high position, base of the commissural posts. Repeat that, but this time doing basilica, and then for illustration purposes, changing the sequence of the valves and starting with the sapien low and then putting the ACURATE. And I'm just going to show you coronary access feasibility in each of these 4 different scenarios, particularly with the left coronary. So let's start first here. This is with the sapien in the low position. And there's 2 things really that I want to point out. The first is relatively easy and straightforward coronary access. So what you saw at the end of that case after native TAVI, you achieve the cannulation quite straightforward. Here, same thing, looks the same with the sapien low. The second thing, however, to point out, as you can see overhanging the sapien, is these sort of fluttering leaflets, this concept of leaflet overhang, which we don't know the hemodynamic impact of yet, but it can act as a barrier for your catheter. So some people may want to therefore implant the sapien higher and so-called pin the leaflets back. And in this specific patient, this is what would happen. So it was unfeasible here to achieve the coronary access to the left. So you can see why that open cell of the sapien, the top row, is normally accessible. It's an open cell. You should be able to access through that. However, you can see the pinned up leaflets have created a sort of a leaflet neoskirt, so you can't get through that. And actually, probably if you see that here with the contrast injection, you really can begin to understand why, and that's simply because the outflow of that sapien is above your sinotubular junction. So there is no way for your catheter to get in. And this is, I think, an important distinction between coronary obstruction, and then coronary accessibility. And what we can see here is if we went and did a high sapien, we wouldn't have access. The question is, what can we do? Is there another solution other than implanting a sapien low? And that's why we tried the basilica. So cut open the leaflet modification, and you can see that previously inaccessible top row of the sapien cells is now accessible, and actually accessible in quite an easy way. You can simply, your catheter goes through, and you can access the coronary ostia. So here it worked. And then just to illustrate, the fourth strategy we tried, just still images, but simply if we reverse the sequence, sapien first, ACURATE second, again, feasible access. So to summarize, in this specific patient, in one of the configurations, you had unfeasible access and you would not be able to get back in, and that was with a high implant. But I think the key learning from this is that feasibility of coronary access for lifelong management, particularly after redo-TAVI, is in your hands as the operator. What you choose as a second valve, the sequence, the depth, and any adjunctive procedures, if you like, it's all things that you can do, but careful planning is required. And sometimes just a redo-TAV strategy might not be enough. You may need specific techniques to achieve the cannulation, but maybe in the interest of time, we can move on and talk about them later on.
Yeah, indeed. No, perfect. Really nice, Arif. Very nice presentation. And very insightful, I would say. It really gives a view on how it works to get coronary access there. What is the impact of implanting this balloon expandable, then low or high, making that neo skirt. So I think, great. Maybe if we have time at the end, I'm doubtful about it, we can talk about maybe more specific techniques that you use then to get into these coronaries. But let's move on now to one. It's please take the floor, and it's your turn to talk about when planning for redo-TAVI, how to perform the CT analysis.
Thank you very much. Yeah, I'm going to talk about what we should be looking at, and I think in the near future, with growing numbers of TAVIs and patients with longer life expectancy, we will increasingly see those cases with a failed TAVI procedure where we have to do TAV-in-TAV. And I think it's a little bit of a different story in the complete planning. And I think we have heard a lot of important aspects in the previous talks with Darren. I think it's absolutely amazing what Arif did and illustrated in these bench testings. I think the microphone.
I'll hold it.
Okay. Yeah. So I have, so the title is CT analysis. I have some additional aspects. Please, I'm gonna. I think there are some aspects which I have summarized here, and I would like to go through all of these considerations. First of all, I think it's very important to, and this is obviously not CT, to identify the mode of failure, and there are different mode of failure which then determine our strategy. For instance, if there's a stenosis, I would try to avoid leaflet overhang, as you have seen on the bench test. Valvular AR would allow more for a little bit of leaflet overhang, and if you have paravalvular aortic regurgitation, this could also be combined. You can consider different approaches, PVL closure or TAV-in-TAV, which would actually address both aspects. I think two of the most important aspects are here, which valve and size and the risk of coronary obstruction and or coronary access. I think these are two different entities, but obviously share similar risk factors. And regarding the valve and size, it's a little bit complicated. So it's not sufficient only to measure the annulus or the narrowest part of the implanted valve. You have to look at different aspects as well. I would always try to obtain the original CT and look at what was implanted originally, what was the original annulus size, and what was the relation between the implant, what was the oversizing. Then, of course, you have to figure out, identify the type and which size was implanted. You have to look at the position. Was it a nominal position, deep or high? And how was it expanded? And the last thing that I would really put emphasis on is, do I expect or do I want the first valve to further expand, especially when you do balloon valvuloplasty or use a second valve implantation, especially if you have a balloon expandable valve, because with a balloon expandable valve, you obviously can overstretch the first implanted valve. And I have a few case examples shown here. This was a balloon expandable valve. I think we did it together. Helge, you did it. And this was done in another center with a, I think, undersized 26 millimeter sapien in a bicuspid anatomy. And you can appreciate that it is not fully expanded. The patient came back with massive paravalvular leakage, and you can see that the original annulus was actually much larger. Maybe the strategy was to undersize due to bicuspid anatomy. And what we did a pre-dilatation with a 28 millimeter balloon and inserted a 29 millimeter S3 with a good outcome. Here's another example. Also in a balloon expandable valve in a relatively small anatomy. The original annulus was 22 millimeter and originally a 23 millimeter S3 was implanted. Patient came back with restenosis, and in this case we decided to implant an ACURATE Neo size 2 after pre-dilatation. And I would like to emphasize, if you want to do modify the stent frame expansion, it is easier to do it beforehand than after inserting the valve. So this is nicely possible. On the other hand, if you have such a constellation with, this is also a Sapien 323, in a bicuspid anatomy, I think you can appreciate the raphe here, and this is an eccentric a position with the valve on this side being adjacent to the sinus wall. And here we did consider implanting an ACURATE, but you could see what I was concerned of is that the upper crown could do some damage to the aortic wall, so we decided to go for another type of valve. In the hindsight, maybe it would have been possible. I think in those valve-in-valve or TAV-in-TAV cases, it could be helpful to do some simulations. So, and here is another case with an evolute that was degenerated with a valvular AR, and you see that this can be really complicated. It was not commercially aligned, and it was difficult what to do. So due to the misalignment, basilica was not possible. And here are some different options that you could take into consideration. You see the massive aortic regurgitation, and in this case, we decided to do an ACURATE Neo, and you can see that the leaflets are patient. I think in TAV-in-TAV, the most emphasis should be on the risk of coronary obstruction and coronary access. And here you see, we have heard it already, there are different valve types out there, and depending on the position of the leaflets, you will create a covered stent if you implant another valve. Arif has shown it very nicely in the bench test. And I would like to emphasize that the risk plane looks higher in certain valve types, but this would also depend on the implantation depth. I think Darren has nicely elaborated that this would be very important. And so it's important to look at the risk plane. You should look at the distance between the valve frame and the coronary arteries, especially if this is below the risk plane. And of course, you have to look at the risk of sinus sequestration. So it's important to look at the complete surrounding anatomy. And in general, I would think that if you have larger anatomies, large sinus, large STJ, and depending also, of course, on the firstly implanted valve, I think that in larger anatomies, you would have less of a risk of redo-TAVI. In the case of ACURATE, this has been also alluded to. I think it's a little bit different. We have the comfort of having natural space between the stand post and the upper crown, so there's a natural VTA of 2 millimeters, which at least reduces the risk of coronary occlusion. Coronary access is a different story, as you have seen here, especially if you have a high implantation. And lastly, I would like to add some procedural consideration. It is really important. Here you can see an example, the orientation of the second valve to enter the valve in a coaxial fashion, not to risk embolization or damage of the first or second valve. And lastly, in case of valve recrossing, I know this is not CT anatomy, but it cannot be emphasized enough that valve recrossing has to be done in a correct fashion. And in order to check whether you have entered the valve outside or inside the frame, you should do this test, which nicely can show whether you have crossed the valve in a safe fashion. Thank you very much.
Thank you, Juan. I mean, really exhaustive and very nice, complete presentation. I think, sorry, we don't have time for questions, but I also want to say that there is a redo-TAV app now from Vinny Babat. And so for all people facing a case where there has to be needed to be done a redo-TAVI, you should definitely check it out. There's a lot of practical, theoretical information in it, but also really to pre-plan your case. So it's an app. I think it's for free to be downloaded. So thank you. And then Andreas, last talk. We only have maximally 10 minutes left. So you have the honor to talk about what are the future steps when moving into TAVI treatment of younger patients.
Thank you very much. I will try to wrap this up in a more general fashion maybe and just discuss, should we go the more or less the US way? Every young patient more or less gets a TAVI, or should we stay in a more conservative European style fashion that most European countries still have with this like kind of 75 years age limit? And I assume the younger in this regard means 65 years. So that's what we're talking about more or less here. Conflicts of interest. So first we discuss how long do these patients actually live. It could actually be that patients with aortic stenosis at age 65 don't live as long as the general population. This has actually been studied. These are surgical patients in Sweden over a long time, and they were studied, stratified by risk and by age of the primary operation. So if a patient is 65 and low risk, you will see blue line, 15 years median survival. Already when you're intermediate risk, your survival on median is less than 10 years at 65 years of age. And if you're high risk at 65, you live on median less than 5 years. So maybe the valve doesn't need to last so many years after all in most patients, even if we go down to 65. There is one important Danish publication this year, this one from Notion. Many have seen it already. This shows the durability on a mix of valves implanted in this study. On the one side, you see the structural valve deterioration over 10 years, and on the other side, the bioprosthetic valve failure. Both of them showing that TAVI is at least not worse than surgery, and the numbers and percentages are low, up to approximately maximum 10% after 10 years. So it shows you that the durability might be quite good in general in TAVI valves. On the right-hand side, you see a publication that is not out yet in Eurointervention. These are patients from Karolinska, follow-up around 4 years on average, all of them with ACURATE, and also showing low numbers of bioprosthetic valve failure. So we probably don't have a problem with the durability, but I think this needs to be discussed in detail, and that's the bicuspid patients, and bicuspids come in different forms and shapes. And in this publication, they divided them into the good and the bad ones are the red box, calcified raphe and excess leaflet calcification, around 1/4 of the patients. And you will see that the mortality in these patients was significantly higher, and not only that, the immediate result with PVL was also clearly worse in these patients. There might be differences between different valve types here, prosthesis types, but we don't have the detailed information yet. I would say there are some ongoing studies with the ACURATE, with other valves, etc. There will even be a European study randomized between surgery and TAVI in general. So I think this matter is not really settled so far. Concomitant coronary disease. I think every meeting I go to, there is at least 1 or 2 presentations showing that PCI doesn't help for anything. Also in this meeting, I think. In the TAVI field, there are at least 2 publications showing that it doesn't matter if you have coronary disease or not, when you look at mortality out to a couple of years later, or readmissions or residual symptoms. There is the activation trial, rather small, but still no difference in death or rehospitalization if you do a PCI or not before. And there's also a study following patients stratified by coronary disease, not single vessel or multi-vessel, and actually a number of patients coming back for a PCI unplanned up to 10 years is even in multi-vessel less than 10%. So this is probably not a big problem either. We already elaborated on the commercial alignment, so this is probably just duplicating what others have said, but you can achieve a very high percentage of non to mild misalignment with the ACURATE system, and it's really quick, less than 2 minutes. Then, of course, if the worst happens, that might be endocarditis for these patients. The rate seems to be rather small, and in a couple of studies, it's very comparable to surgical treatment, so there seems to be no difference. Interestingly, if you look at these patients, only half of the endocarditis actually is on the aortic valve, and it's quite rare that the valve is destroyed, meaning that it leads to an TAVI explant. But say that the worst happens, you get endocarditis and you want to explant the valve. Is it better to have a short frame balloon expandable or a tall frame self-expanding? Interestingly, there seems to be no difference according to the largest study so far published this year. The risk is quite high for the patients regardless, but it's no difference between a balloon expandable and self-expandable when you explant the valve. So in short, to summarize, I think the main issue is the bicuspid patients where we need more data, and more data will come. Durability, I think, is in general not a problem. Endocarditis explant might happen, but it's not really a difference to the surgical treatment initially. Concomitant coronary disease seems to be more or less irrelevant, I would say, slightly provocatively. And commercial alignment is easy to achieve. But if you want to have a patient-specific commercial alignment and rotate actually where you deploy the valve, the ACURATE so far is the best for that. So to summarize, no big deal.
Andreas, thank you very much. This was a perfect conclusion for the whole session, I would say. We talked about the lifetime management of patients with aortic stenosis, on how to treat them best. It is important, and that we try to show, to have a deep look into the patient anatomy, but also into the clinical presentation, whether the patient will probably need a second valve or not. We had a very good insight into the design of the different valves and what to consider, which valve to take first, to take second. We had a really great case. This was a straightforward case, but it showed nicely on how easy the implantation of an ACURATE valve can be performed and how safe this is. We had a couple of consideration towards valve in valve, and not so much on valve in surgical valves, but TAV-in-TAV. And here it has been shown that CT planning is really important in order to take all anatomic aspects into consideration. And last but not least, we had the talk about the future steps when we are treating younger patients. I would like to thank all speakers, panelists, and of course you as the audience for this great session, and wish you a very nice evening here in Paris.